Listeners, welcome to lecture 47. In our last session, we examined innovative approaches in reproductive and child health service delivery, where we looked at new models, technologies, and partnerships. Today, we take the discussion forward by reviewing real world case studies of successful RCH programs. Case studies allow us to understand how theories and models translate into practice, what makes programs effective, and how lessons learned can be scaled and adapted. We will examine both global and Indian experiences to capture a broad perspective. Case studies are more than just stories, they are evidence based learning tools that help policymakers and practitioners understand what works and what does not. By examining successful RCH programs, we can identify strategies worth replicating, barriers to avoid, and opportunities for innovation. These real world examples also provide evidence that guides governments and NGOs in shaping policies and programs. The case studies we explore today are selected based on clear criteria. They must demonstrate measurable impact on maternal and child health, reflect innovation that can be scaled to different settings, and involve strong community participation. Community participation is heart of the success of all program implementation. These elements are very critical in ensuring not only success but also sustainability of interventions. One of India's most recognized programs, Janani Suraksha Yojana, is a conditional cash transfer initiative aimed at promoting institutional deliveries. By providing financial incentives to pregnant women, especially those from below poverty line households, JSY has significantly increased the number of institutional deliveries and contributed to reductions in maternal mortality. This program demonstrates how financial barriers can be addressed through simple direct incentives. It works best when payments come on time, transport to facilities is available, and accredited social health activists, that is ASHAs, guide women before and after birth. Many families also seek antenatal and postnatal care more confidently when they know key costs are covered, though remote and marginalized groups can still face gaps. To keep improving, JSY should stay cashless at a point of care, cut paperwork, and link closely with Janani Shishu Suraksha Karyakram and Pradhan Mantri Matru Vandana Yojana, so mothers and babies get continuous support. The impact of JSY has been profound. Studies show increased institutional deliveries across states. Even in remote regions, this has translated into reductions in maternal and neonatal deaths as women receive skilled care during childbirth. Importantly, JSY has empowered women to make health-seeking decisions, with many citing the incentive as a motivator to access care they otherwise could not afford. Case study 2 is about India's ASHA program. It was launched under the National Rural Health Mission. It is another landmark success. ASHAs are community health volunteers who serve as a bridge between the health system and the communities. They provide counseling, support to institutional deliveries, and mobilize for immunization and promote family planning. Their grassroots presence ensures that services are accessible even in marginalized communities. They make regular home visits, spot danger signs in mothers and newborns, and help families reach health clinics in time. ASHAs work closely with schemes like Janani Suraksha Yojana and Janani Shishu Suraksha Karyakram, so women receive cash benefits and free care without hassle. To keep their impact strong, timely payments, ongoing training, and supportive supervision are essential. This simple community based model shows how trusted local women can connect families to life-saving services. The ASHA program has been credited with remarkable improvements in RCH indicators. Institutional delivery rates have been risen. Immunization coverage has expanded and awareness about family planning has increased. ASHAs have built trust within communities, making health systems more approachable. This trust is a critical element of their success and sustainability. BRAC, this is another case study about Bangladesh. This BRAC in Bangladesh offers a global example of large-scale NGO-led success. Using a community health worker model similar to ASHA's, BRAC provides maternal and child health services, family planning and nutritional interventions. Their door-to-door approach ensures services reach even the poorest households. BRAC's integration with health, with education and livelihoods adds to its sustainability. In many areas, supervisors coach workers regularly and use simple tools like checklists and reference slips to keep quality high. Strong links with government clinics and microfinance groups help families act on health advice and manage costs. This shows that combining home visits with education and income support can improve results and keep the program strong over time. This BRAC model has demonstrated measurable improvement in child mortality and contraceptive use. By integrating health with microfinance and education, BRAC has not only improved health but also empowered communities economically and socially. This multi-sectoral approach illustrates how addressing social determinants enhances health outcomes. Now the example of a case study from Nepal. Nepal's Safe Motherhood initiative showcases successful government and NGO collaborations. The initiative expanded across to skilled birth attendants and implemented maternal death audits to identify gaps in care. These interventions have contributed to a significant decline in maternal mortality, making Nepal one of the few countries in South Asia to achieve remarkable maternal health progress. Simple steps make a big difference, like training more midwives, setting up birthing centers closer to villages, and arranging transport for emergencies. Maternal health reviews led to practical fixes like better referral plans and stocking essential drugs. Continued focus on remote mountain areas, timely ambulances, and respectful maternity care will help Nepal keep improving. This program of Nepal led to increased skilled birth attendance, resulting in safe deliveries. Maternal mortality ratios dropped significantly over the years. Maternal death audits introduced accountability, ensuring that health systems learned from each case. The success demonstrates the importance of combining service delivery with system level accountability. Gavi, it's a global alliance that strengthens immunization systems in low income countries. By leveraging public private partnerships, it has expanded access to vaccines for millions of children. Gavi's innovative financing and coordinated partnerships have transformed child health outcomes worldwide, especially in regions with weak health systems. It also invests in cold chain equipment, train health workers, and helps countries track who is still missing vaccines, especially zero-dose children. Gavi's co-financing approach means governments gradually share more costs, which builds long-term sustainability. In health emergencies, Gavi supports rapid vaccine rollout and delivery supplies, working closely with the World Health Organization and UNICEF. This mix of funding, training, and a strong partnership makes routine immunization more reliable and more equitable for the population. Gavi has been instrumental in expanding immunization coverage, reducing the incidence of disease like measles and polio. It has also strengthened health infrastructure by supporting cold chain systems and training health workers. Gavi illustrates how global partnerships can achieve large scale impact on child health. Another case study from Pakistan. Pakistan's community midwives program is another inspiring example. By training local women as skilled midwives, the initiative improved maternal health care in rural areas. These midwives provide antenatal care, safe deliveries, and postnatal follow up, reducing risk associated with home births without skilled attendants. They also build trust because families know them personally and can call them quickly in emergencies. The strong referral links to nearby health facilities help transport and steady supplies like clean delivery kits and essential medicines, making their work safer. Regular supervision, fair pay, and ongoing training helps midwives keep their skills sharp and serve remote communities well. Community midwives have increased the proportion of safe deliveries in rural Pakistan. Maternal and neonatal deaths have reduced as more women seek their services. Importantly, because local women midwives are trusted and accepted by communities, making this program culturally appropriate and effective. Rwanda's community based healthcare insurance, known as Mutualas de Sante, is an innovating financing model. By pooling the community contributions, Rwanda has moved closer to universal health coverage. This scheme particularly supports maternal and child health by reducing financial barriers to accessing services. Premiums are kept low and poorest families receive government subsidies, so no one is turned away for lack of money. Enrollment at the village level makes sign up easy, and people can use services at local clinics and hospitals without heavy out of pocket expenditures. Strong record keeping and regular renewals keep the fund stable, while community oversight builds trust and accountability. The impact of Rwanda's insurance scheme is evident in increased health service utilization, reduced financial burden on households, and improved equity in access. Maternal and child health indicators have shown steady progress, reflecting the effectiveness of reducing financial barriers. IMCI, developed by WHO and UNICEF. Another form of IMCI is IMNCI, which is a modified form used in India, where we have added the neonatal component also. So this IMCI, which was developed by UNICEF and WHO, provides an integrated approach to child health. It focuses on treating major childhood illnesses, promoting nutrition and preventing disease. By combining preventive and curative services, IMCI addresses child health holistically. Countries implementing IMCI have reported significant improvements in child survival. Health workers use simple color-coded charts to decide treatment quickly and refer severe cases without delay. IMCI also teaches caregivers about feeding, danger signs, vaccination and hygiene during the same visit, saving time for families. Regular follow-up and growth monitoring help catch problems early. With better record keeping improves planning at clinics. When supplies, training and supervision are steady, IMCI leads to fewer deaths from pneumonia, diarrhea and malaria. IMCI has contributed to reductions in child mortality in many countries. Caregivers have improved knowledge about managing childhood illnesses, while health workers have better diagnostics and treatment skills. IMCI has also strengthened primary health systems by emphasizing comprehensive integrated care. Conditional cash transfers in Latin America link financial support to health and educational behaviors. For example, families receive cash if children attend school or complete immunization schedules. These programs, like Oportunidades in Mexico and Bolsa Familia in Brazil, have shown improvements in child nutrition and reduced poverty, highlighting the power of linking health with social protection. They also motivate regular contact with clinics and schools so problems are caught early. When payments go to mothers, women gain more decision making power at home. For best results, governments must keep payments timely, make rules clear, and ensure clinics and schools have enough staff and supplies. This simple mix of cash plus conditions turn good intentions into steady and healthy habits. These programs have improved child nutrition, reducing stunting and increased immunization rates. By addressing poverty, they indirectly improved health outcomes. Conditional cash transfers also empower women, as payments are often made directly to mothers, strengthening their decision-making role in households. And presence of money in the family is also directly related to the nutritional diversity that is being used by the family and perhaps by the children of the family. So, poverty and income are directly related actually to the health and nutrition of the whole family. Across these case studies, common themes have emerged. Community involvement ensures sustainability. Government and NGO partnerships enhance reach and quality. And integration with social protection addresses underlying determinants of health. These themes provide valuable lessons for designing future RCH programs. To act on these lessons, keep services close to people through trusted community workers and local women groups. Remove cost barriers, cash support, insurance, or free care at the point of service, and make payments timely. Building of strong links across health, nutrition, education, and livelihoods is very important so that families go complete support in one pathway. Use of simple data tools like death reviews, scorecards, and follow-up registers is very important to spot gaps and fix them quickly. Prioritizing equity by tailoring outreach to remote, poor, and socially excluded groups, and involving of communities in planning and feedback to building of trust. Finally, start small, evaluate, and scale what works while allowing local adaptation so programs stay effective and affordable over time. The lessons are clear. Empowering communities is critical for long-term success. Financial incentives reduce barriers and encourage positive health behaviors. Integrated approaches that combine health, education, and social protection are more effective in addressing the complex challenges of reproductive and child health. When communities help plan and monitor services, programs last longer and fit local needs. Pair cash or insurance with reliable transport, respectful care, and clear information so families actually use services. Link clinics with schools, nutrition schemes, and livelihood supports to tackle the social roots of poor health. Track results with simple data tools and fix gaps quickly with extra focus on the poorest and the most remote families. Innovation played a role in most successful case studies. Whether through digital health tools, innovative financing like cash transfers, or new delivery models like community health workers, these programs adapted to their contexts. The flexibility and creativity were key to their success and sustainability. Political will was another common factor. Successful programs led strong government commitment, enabling them to scale and sustain innovations. Policy support provided the foundation while investments in health systems ensured continuity. Without political will, even well designed interventions cannot achieve a lasting impact and cannot be sustained for long. Despite success, challenges remain. Many programs struggled with sustainability beyond donor support. Ensuring equity during scale ups was another concern, as marginalized groups risked being left out. Cultural resistance, such as reluctance to adopt family planning, also posed barriers. Addressing these challenges is essential for replicating success. To move forward, countries need stable domestic funding, simple monitoring to track who's being missed, and culturally sensitive counseling delivered by trusted local workers. Partnering with community leaders can reduce resistance and improve acceptance of services. Equity focused outreach, such as mobile clinics, transport, help, and multilingual materials, keep the poorest families included. The future lies in scaling proven models while adapting them to local contexts. Integration with universal health coverage frameworks will ensure sustainability. Rights-based approaches must guide reproductive and child health programs, ensuring that services are delivered equitably and with respect to dignity and autonomy. To summarize, case studies provide us with practical lessons that go beyond theory. Success consistently depends on community engagement, innovation, and strong political will. You have a best program, you have everything, and you don't have a political will, then it's very difficult to even start that program or continue it or sustain it. However, no program can be replicated exactly. So, adaptation to local contexts, local culture, local needs is the key to making case studies useful and impactful. In conclusion, case studies serve as blueprints for advancing reproductive and child health. They provide evidence of what works and inspire the design of new programs. By learning from successes and challenges, policymakers and health professionals can build stronger, more inclusive RCH systems that deliver real change. As we close in this session, I want you all to reflect on the idea that every successful program represents resilience, innovation, and the power of communities to transform their health outcomes. The power of communities, the power of participation at the grassroots level is the real stimulation we need for the progress of any program. By studying and sharing these stories, we not only celebrate achievements but also pave the way for replicating and scaling success. These case studies, they remind us that progress in reproductive and child health is both possible and achievable when systems, communities, and innovations work in an aligned manner. So, thank you so much. That's all for today. Next, we'll take up chapter number 48, which deals with challenges in community-based RCH programs and solutions. Thank you.